I was a fellow at Boston Children's, I always liked electrocardiography. I don't know why, it just appealed to me for some reason. MacDonald Dick had already left our institution. We didn't really have an electrophysiologist, and Dr. Natus had condemned poor Dr. Barry Keene to be the EP person. And Barry liked the cath, and I'm not sure he was real sold on the EP world. But when Natus told you to do something, you did it. So he picked it up. And I think he saw the spark in my eye when I was learning electrocardiograms for him. And he put his arm around me and said, "Son, I know what we're going to do." So he got off the hook and I got on the hook. But when I was still a fellow, he took me to one of the meetings. It must have been, gosh, around 84, 85 that I went to my first meeting. And it was very interesting. The room was almost packed, as I recall. In those days, a lot of people showed up. And there was a little hiatus in the late 80s where people stopped going. But in the mid-80s, the rooms were packed. Everything was new. So if you picked a topic to discuss, everybody was keen to discuss it because nobody really knew what to do in the pediatric world. So that was my initial exposure. I think I've been to every PACES meeting since 1984, and it started to get a little scary when we had a meeting down in Orlando, and I think about 7 people showed up, and that was in the late 80s. And then what happened is the catheter ablation registry was set up by John Kugler, and I think that reinvigorated the society. Everybody started showing up again, and the rooms were once again packed, so it was very good timing. The organization has, what started out, you could look around the room, you knew everybody. But now when you look around the room at some of these PACES meetings, a lot of people are complete strangers, which I think is good. It says a lot about the growth of the organization. More allied professionals come to the meetings now. More young fellows who are joining the field come to the meetings now, and it's a very vibrant society. A lot of fun. Well, the nice thing about it, and you can talk to anybody who entered the field in my era, you could make up your own job description, which was terrific. You could get involved in whatever angle of electrophysiology you wanted. I tried very strongly to remain a general cardiologist who did electrophysiology. I still took care of a lot of hemodynamic cases, and I'd advise that for any young person entering the field. I think you make much better EP decisions when you're a good general cardiologist first. When I was about to enter the field and looking for a fellowship, Texas Children's was training people then, but I had talked to the adult electrophysiologist across town in Boston at Mass General, and I was sort of intrigued by some of the stuff they were doing. They were starting to do catheter ablation with DC energy, and they had this newfangled device. They were one of the few centers in the country that had this newfangled device called a defibrillator. An ICD, and they used to be rationed 1 device a month by CPI, which was the company making it. That's what Guidant was called before it was Guidant, before it was Boston Scientific. It was called CPI. It seemed to me that that was going to be an interesting experience, so I went to Mass General to do my training with an adult electrophysiologist. And the great thing about EP is that the crossover between adult and pediatric electrophysiology is pretty vast. So I wasn't a complete boob when I went there as a fellow. I didn't know a whole lot about ischemic heart disease, so they had to keep me out of trouble, but they assigned somebody to make sure I didn't make any stupid decisions. But the EP part of it was very translatable to what I encountered when I went back to Boston Children's to start a program there. I like the fact that EP has a lot of puzzles involved. I like the fact that we map stuff. I love maps. I mean, ever since I was a Boy Scout, I think I loved maps. And the idea that you would map the heart really appealed to me. I like doing invasive procedures. I mean, I also like taking care of patients. I love the fact that I can do longitudinal care, not just through pediatric age group, but at our center, adult congenital as well. You know, a lot of my patients that I picked up, now that I'm old enough, picked up when they were infants or now having children of their own. So I like that continuity of care. The job description for an electrophysiologist should be cardiologist first, electrophysiologist second. I mean, how else can you do adult congenital? If you don't understand the anatomy really well, the physiology really well, you shouldn't be doing procedures in those patients, is my opinion. Well, as you know, I'm pretty interested in the history of our field. Mac Dick and I did a paper on the early days of PACES because he was around at day one. I wasn't. But we can trace the origin of it to 1980, which is when Grace Wolf in Miami set up a little satellite symposium during one of the AHA meetings. And I think there were 16 people at that original meeting. And they wrote a paper on ventricular arrhythmias in pediatrics that was published, I think, 2 or 3 years later. But the preamble to that said we expect to have a yearly meeting where we discuss topics of interest in pediatric electrophysiology, and that largely happened. I think it really gelled around 1982 or 83. I mean, you can talk to Mac about that and get more specifics, but eventually it got a constitution. It got registered as a nonprofit organization. There were some, as I mentioned earlier, some major things that made the organization grow. And one was the ablation registry. Another was the NIH-sponsored APGA trial that George Van Heer was involved in. This sparked interest in a lot of people. I think it's interesting now how vibrant the allied professional side of PACES is getting, because as physicians, we all know that if you latch onto somebody who's interested in the field and can keep them for a while, it really makes your life and the patient's life much better. To have people just rotating through for a year at a time, it's hard to build a service that way. But if you get dedicated people, nurses and techs who are with you for a long time, it really helps your program. It makes your life easier, and it certainly makes the patient's life easier. But PACES is, I think the philosophy has always been, it exists to do collaborative research. And it's no accident that the ablation registry and PACES were a real shot in the arm for the organization, because that's what it's there for. And the social part of it's fun too.
Very good. Anything else, any other comments you would like to make?
Nope.
I figured as much.